Greetings, everyone. Welcome to another edition of Cosmetic Corner. This ASJ segment is designed to critically analyze an article in each issue of ASJ. Our objective is to utilize experts in the field of aesthetic surgery to help us evaluate and really extract the key practice changers from these peer-reviewed works. Today, we are very fortunate to have Dr. Ali as our expert discussant. Dr. Ali is a very well-respected aesthetic plastic surgeon who has specific expertise in body contouring surgery. He serves as a body contouring section editor for ASJ and is currently a consultant plastic surgeon at the Cleveland Clinic in Abu Dhabi. We are honored to have you with us here today, Dr. Ali. Thank you for being here.
Thank you very much, Chris.
Now we're here to discuss a very interesting article out of UT Southwestern titled Personal Evolution in Thighplasty Techniques for Patients Following Massive Weight Loss. We commend the authors for a very interesting article on a highly relevant topic. The premise of this study was to perform a direct comparison of Colleys fascia suture fixation, as espoused by the late Dr. Ted Lockwood, versus utilization of horizontal vector fixation, as utilized by the senior author, Dr. Jeff Kenkel. Additionally, there is suggested undertone that incorporation of barbed sutures and liposuction may increase aesthetic results in this operation. Let me start with some opening thoughts on the article. I very much applaud the authors on a creative design by creating comparison groups in a retrospective manner. Strengths of the design are that the operations were all performed by the senior surgeon, and although the sample groups were not completely equal, in other words 40% and 60%, they were very close. There is an obvious bias that the latter group undergoing the horizontal vector fixation are also being done by arguably a more experienced version of the surgeon in the study as he progressed in his technique. But of note, they did make an effort to separate liposuction and barbed suture as secondary endpoints. So Dr. Ali, let's dive right in and talk about some components of this article. First, let's discuss the concept of Colleys fascial fixation. When originally described by Dr. Lockwood over 25 years ago, this concept led to a significant decrease in morbidity. However, as with many surgical techniques, we've evolved in our approach to this operation. And as we know, this operation gets even more complicated in the massive weight loss patient, where the authors keenly point out that inelasticity in the atrophic dermis antagonize the surgeon in his attempt to get an optimal result. So my first question to you, Doctor, please share with us your take on Colleys fascia fixation versus this horizontal vector technique.
Okay, well, Chris, I think the first thing I'd like to mention is that Dr. Lockwood's original technique was designed for a very different patient population than the massive weight loss patient. So his original group of patients were people who were normal weight, have a little bit of vertical laxity in the medial thighs, and in non-massive weight loss patients. So the quality of tissue that we were dealing with and essentially trying to fix are very different than massive weight loss patients. So now if we move over to the massive weight loss patients as opposed to that group of relatively young, relatively good skin elasticity group, we move to a completely opposite group that's really quite the opposite in quality, especially. So Colleys fascia is an interesting place to suture to, and certainly it was a good addition to the original group of people that Lockwood dealt with. The problem with massive weight loss patients is not the Colleys fascia side, it's what do you attach the other side of the suture to. You're attaching it to sutures or to tissue that is very lax, and basically you can cheese wire right through it in most massive weight loss patients. The other major problem is that the deformity that these patients have is different than the deformity that the patients that Dr. Lockwood dealt with. So in the original, it was mostly a vertical issue, meaning that there was vertical descent or lack of tacking up of the medial aspect of the thigh. Massive weight loss patients have mostly horizontal excess. That's their major problem. Vertical excess, there's a certain component of it, but it's really the minor aspect of the two. So it's a little bit like if you compare it to the world of brachioplasty, where you're doing a horizontal excision in the axilla only to treat massive weight loss patients. you end up with the same problem, is that you're trying to treat a horizontal problem with a vertical lift. So what I always tell people is you can drill a bone into the pubic area, drill the bone there and put a suture through it. But what's the other end attaching to? It's attaching to tissue that just basically can't hold your suture. So that's the huge problem. On top of it, there's a tremendous amount more weight that these sutures have to hold on to than the original Lockwood patients. So for me, it's basically a procedure that is not usable in massive weight loss patients, meaning the horizontal excision that Lockwood originally espoused. So Dr. Kenkel's approach is a very good one because he takes the tension off of that vector and creates it in a horizontal fashion by doing a vertical excision.
I see. Excellent response. Thank you. Dr. Ali, what is the most common complication you see in thighplasty patients, both in your patients or those that present to you for maybe a secondary operation? And what adjustments have you made in your personal technique over the years to help decrease any unwanted complications?
Okay. You'll have to remind me of all those different segments, but probably the most common thing I see is either little wound separations or wound separations overall. And a little bit longer term, I see either seromas / lymphoceles in the distal third of the thigh. That's probably the things that I see in my patients. The things that I see in patients that are referred to us are problems with the position of the scar that's created horizontally, meaning in the perineal crease. And unfortunately, that is a huge problem because most of the people that I see, the scar is not in the perineal crease. It has moved on to the thigh. And unfortunately, in a certain number of patients, it's led to labial spreading. And even though those are not as common, I don't see them as commonly, each one of those is almost a disaster, as opposed to dealing with wound separation and seromas or lymphoceles. These are relatively minor in the big scheme of things. So that's kind of my experience. And what have I done differently? How have I adjusted? Over the last 20 years or so, I've stopped all horizontal components. I don't do horizontals at all. All my excisions are vertical only, which is a little bit less than what Dr. Kenkel does, meaning in the attempt to improve that area superiorly. I have some tricks to making things work, but I think that's not the point. The point is my tension is created in the same fashion that Dr. Kenkel's procedure has, and I avoid all tension created on the labia.
Okay, very good. What are your thoughts on the barbed suture and the concomitant liposuction to help create a discernible dissection plane in these patients? So for me, I like barbed sutures quite a bit. I've been using barbed sutures for probably around, 12, 15 years. As soon as they came out, I started using them. Now, unfortunately, I'm not able to use them in certain procedures. So I use them very much in belt lipectomies. I do my plications with them. I do most of my wound closures with them. But I have a bit more of a difficult time with using them in thighs and arms, mostly because I have to have the correct plane to put them in. Okay.
So in thighs specifically, I use extensive liposuction in the area that I'm going to resect.
Okay.
So with the idea in mind, I think like the authors and Dr. Kenkel, is that you're defatting or taking the load off of the area that you're going to resect, and you're leaving behind hopefully a lot more lymphatics than you would leave behind if you took it out in one on-block resection. And when I do that, because of the extensive liposuction, I find it hard to have enough tissue to hang on to with a barbed suture. So, and I think that makes it a little bit more challenging if you're trying to do it in that situation. I think if you're not doing that sort of defatting or extensive debulking, you probably would use barbed sutures, and you'd be a little bit more comfortable with that. The other aspect of it that is important for me with barbed suture is I use a long-lasting, non-permanent barbed suture.
Okay.
And if you put that anywhere close to skin, it will spit on you in a very bad way. It will get infected.
Okay.
And so if you've done this level of liposuction, the only thing that you've got left is to catch on to the dermis. And that's a little bit too close for those sutures for me to be comfortable. So I avoid that. Now, I'm sure that in Dr. Kenkel's technique, he probably leaves a little bit more tissue to hang on to, and that's why he's able to do it. I think if you are able to do it, I think barbed sutures are advantageous over either interrupted or non-barbed continuous suture. I think they really do have a major advantage.
Excellent. Do you have any tricks to make sure you get the knee done right the first time without having to do a revision? They mentioned this transverse suprapatellar incision in their technique. What are your comments on that?
I think it depends a little bit on the extent of the suprapatellar problem. If you have a true panniculus there or a little hang when you're ready to do your thigh reduction, I don't think any technique will completely eliminate that unless you do what they describe, which is go across in a horizontal fashion. Whether you do it primarily or in a secondary procedure, that's kind of up to your comfort level with what you can do in one sitting. But if the patient doesn't have a major panniculus there, I think you need to cross the knee onto the below knee level with your vertical excision in order for you to be effective. If you stop above with somebody that has a lot of knee fullness, you will not get rid of that, meaning the knee fullness, and then you will not get rid of the suprapatellar fullness. So in essence, in those patients, you must, at least in my hands, cross the knee onto the below knee component of the calf.
All right, so Dr. Ali, at this stage, we're about to wrap up the interview. I wanted to open it up for you to give us any final comments you may have to share.
My take-home message is that you really need to avoid migrating scars, and you definitely need to avoid labial spreading. In our U.S. environment, if you get sued for that, there's a very good chance that you will lose, and you might even lose your license for that. So it's a very smart idea to stay away from procedures that lead to that.
Well, Dr. Ali, thank you so much for all of your expertise discussion on the article. Again, we want to commend Dr. Kenkel and his co-authors for an excellent article on ASJ. And thank you again for joining us, Dr. Ali.
My pleasure, Chris. My pleasure.
And we'll see everyone on the next edition of Cosmetic Corner. Bye, guys.